So we'll start with Dean Ramage. Dean has helped us out in the past with our students preparing for health sciences, and he liked it so much that he went on and did a year of research in Otago, which led to a Bachelor of Medical Science with honours. Is that right?
Yep.
Yep, and that was on something that's... Any orthopods in the room? It was on basically the consequences and the impact of delays in doing orthopaedic cases, and it's good to have Dean back. And Dean's going to talk about DNA, but not the triple helix, DNAs, and sponsored by mainly with orthopaedics. Yep. And supervisor was Bronwyn Anstis.
I'm just going to start while Sarah's bringing it up because time's short. My name's Dean. Thanks for the introduction. And yes, I slotted into the DNA project that's going on throughout the hospital at the moment. So looking at non-attendance in outpatient clinics. So I was asked specifically to look at fracture clinic and orthopaedics outpatients in particular, and also paediatric outpatients in Whakatane. So for those that aren't aware of the DNA project, the DHB has set a target for non-attendance rates at outpatient clinics to be below 5%. And at the moment, most outpatient services aren't reaching that target. And paediatrics and orthopaedics in particular show quite high rates. So these are just a quick look. You can see that oncology is very low, predictably, because of the emotional tag that goes along with that, but things like orthopaedics and paediatrics are up around that 10% mark, so double what we really want them to be. So the bulk of my time I spend in fracture clinic, so I'll probably speak about that most today, just because time is short, but if I do have time I'll go to the findings that we came across in Whakatane in paediatrics. So basically what I was asked to do was go in there, find out who's showing up and why they're showing up for their appointment, any barriers they have to attending, any suggestions they have for improving the booking process and ways to enhance attendance, that kind of thing. And then who isn't attending and why they're not attending. So reasons for not showing up, again, any barriers to attending, that sort of thing, similar lines. And then using that, figure out ways to improve attendance in those clinics. So what I did was develop a bunch of questionnaires based on things used in previous literature. So for those that did show up for their appointment, they were given a questionnaire prior to their appointment to get an idea of what they expected the appointment to be about, the value of that appointment, any barriers to attending, etc., etc. And then they're given a questionnaire straight after again as well to compare their expectation with their satisfaction. Their doctors were also given a questionnaire for each of their patients, again to gain an idea about the appointment itself, the value and the importance of that appointment, any impacts on the health of the patient if they hadn't shown up, that sort of thing. And then for those that didn't attend the appointments, they followed up by phone and did the questionnaire again along similar sorts of lines. So just quickly, we saw a couple of hundred patients in fracture clinic, which was great, and saw the doctors as well, had questionnaires completed there. And during the 2 or so months that I've been here, the DNA rate was sitting at around that 10% mark. And it kind of backed up some of the data that had already been produced. So higher in Māori in that working age group, and particularly males in that working age group, which was interesting. And the biggest reasons for not attending were forgetting about the appointment or failing to cancel or reschedule, which actually backed up findings from past literature, which was interesting. And for those not attending, there was a high demand for a text reminder. So at the moment, or when the study started, there was no text or phone reminders for patients for their fracture clinic appointments, unlike there is that for most other outpatient services. So there's a high demand there, and when we looked at the appointments that they were missing, most of them were for long-term follow-ups. So they have a cast on their arm, they show up and they get that off, but then that's it, they're not showing up for their later appointments. So again, there's just a quick look at the demographic of those who aren't showing up. So again, the Māori are overrepresented in that working age group, along with their children, so those in the age group. Is that 4 minutes already? Wow. So let me quickly race through. For those that did show up, parking was the biggest thing by far that came up there, also things like transport. They also wanted a text reminder, and when we looked at how they valued their appointment, the patients tended to value their appointment very high. Some were being disappointed, but most of all there was a high satisfaction rate. But a lot of the appointments were reported by the doctors to be low importance, low impact. If the patient hadn't shown up, there wouldn't have been really any effect on their health or recovery. So we'll just skip through this. So what we did, 2 weeks ago, a text reminder service started for Fracture Clinic, which is great. The DNA rate has dropped down to near that 5% mark. The difference in rate isn't statistically significant yet, but it's heading that way as we collect more data, which is awesome. And we've also started trialling SOS referrals, which is self-referral of symptoms. So rather than a patient possibly being followed up 6 weeks later for a clinical review, and where they might or might not need it, they're discharged and given a 6-week window where they can make their own appointment if they feel they need it. So that way we're reducing the clinic appointment volume and hopefully having a follow-on effect on the DNAs. And our first pharmacy student, Holly Boyle. Holly's going to present two talks today. Holly's a prodigious sportswoman. She's representing New Zealand for both swimming and volleyball. And we've been lucky to have her services, and she's looked at, she's done a pharmacy project and a rheumatology project. The supervisors have been Casey Murati for pharmacy and Tim Sol for rheumatology, and our thanks to them. Holly.
Hi everyone, as Peter said, my name is Holly and I'm a pharmacy student from the University of Otago. During my time at the hospital, I've spent half my time in the pharmacy and the other half of my time doing a project for Dr. Tim Sol in rheumatology. Today I'm going to present one study I did in the pharmacy and then do a brief summary of the things I've been doing with Dr. Tim Sol, as we're currently still in progress. So the project I completed for the pharmacy was titled Pharmacist Contributions to Ensuring Safe and Accurate Medication-Related Discharges. This study took place in the Transit Lounge at Tauranga Hospital. Pretty much the study will explain why a part-time pharmacist will be a beneficial member of the Transit Lounge team just to optimise the discharge process. So the study objective was to audit the impact of a Transit Lounge pharmacist's contribution on discharge. Pretty much a pharmacist's contribution can be defined as any help that the pharmacist has given or any change that they have made to the prescription or discharge summary. So how did we do this? A pharmacist and myself were present in the Transit Lounge for 5 days from 10:30 to 2:30. Each summary and prescription was assessed using a standardised form. Any pharmacist's contribution to discharge prescriptions were recorded and rated for potential clinical impact. Medication-related counselling was also recorded. Cool, so this here is the standardised form which I filled out for each patient. On the right hand side here we pretty much have just general patient demographics, some pharmacist input stuff, and on the left we have pharmacist contribution by type. Now for the results, of a total of 34 patient discharge summaries, 0.82 or 4 of every 5 prescriptions required a pharmacist contribution. So of the 25 contributions made, 3 of these were rated moderate to severe patient harm. 50% of patients were also deemed to require and were subsequently given patient counselling. So this was one of the critical interventions made by the pharmacist, the identification of an interaction between dabigatran, which is an anticoagulant, and carbamazepine, which is an anticonvulsant. So pretty much carbamazepine causes subtherapeutic levels of dabigatran by decreasing the serum concentration by about 2/3. Therefore, increased risk of blood clot and subsequently heart attack and stroke. The pharmacist then rang the prescriber and got dabigatran changed to warfarin, as this is more easily monitored by looking at INR. Here we have a graph of pharmacist contributions by type. So as you can see, wrong or missing dose was the most common contribution made, followed by drug interaction. In conclusion, a total of 16 patients discharged prescriptions required at least one clinical intervention. The most common category for contribution was wrong or missing dose, followed by drug interaction. And pretty much previous studies show very similar results, with one study in England with a much larger sample size, averaging 1.4 contributions per prescription. These are my references, and I'd like to say a massive thank you to Casey Murphy, the clinical pharmacist involved, and Melinda Arnold, the registered nurse at the Transit Lounge. I'm just going to do a quick summary now on the methotrexate intolerance study that I'm currently doing with Dr. Tim Sol. It is a retrospective cross-sectional study, and it's currently in progress. I'm just going to do some interesting statistics that I've got so far, because we've pretty much just got to the data analysis point. So some interesting data. Of the 505 patients, 73% were females and 27 males. The average age of people was 65 years old, and the average number of years since diagnosis was 15. Here we have the medications used by rheumatoid arthritis patients. As you can see, methotrexate is the main one, followed by leflunomide, and yeah, 68% of patients with RA are currently on methotrexate. This is the last slide here, adverse effects of methotrexate. So there are a total of 126 reported adverse effects. From this, we've had 75 patients taken off methotrexate. 18.5% of males were on methotrexate stopped it, yet only 13.6% of females needed to stop it. So therefore, females seem to be a bit more tolerant to methotrexate than males.
Marinus Marinus is also a local lad. He was Ducks and Head boy at Bethlehem College. He's off to Thailand after this, I see from the cheat sheet here. Yeah, so I hope you enjoy your holiday. Come on up and tell us about your survey of MSOP clients and carers. Thanks to Fiona Miller and Dawn Wilson.
My name is Marina, and I'm a second year medical student at the University of Otago. So in my time here, I've been doing two projects, both with the mental health services, but one of them was with the Te Whare Mai Angi, sort of just a client satisfaction sort of thing, but just due to time, we'll just be talking about this one. So this was with the mental health service for older persons, and essentially the background behind this is they've been trying to get people more involved in the planning and development, but it just hasn't been working. So my role is to find out if people are interested, if they're interested, whereabouts would they be interested, and the barriers to involvement. So we did this by just making a questionnaire, and then we used structured interviews to fill them out, and this was either done in person or over the phone. To get our participants, we went to COS, which is the Community Outreach Service, and they just run various activities such as a walking group or a craft group. And we also went to the inpatient area and asked case managers to identify anyone they thought might be suitable. Our inclusion criteria is just anyone who was a carer or client of the service, and the only exclusion criteria is if we thought someone wasn't competent or capable of understanding the survey or something like that. Cool, so this is the questionnaire shortened. So did you know that you could be involved? Do you think that carers and patients should be involved? What areas would be interesting to you? What ways consulting or contacting would work for you? What would make it difficult for you? And overall, how keen are you to be involved? So in the end, we got 32 clients and 15 carers, and what I've done there is just compared the client demographics from our study to the client demographics of the service in general. And as you can see, for ethnicity and gender, it's matched pretty well. Ethnicity is just a couple percentage off here and there. Gender's pretty much bang on. Age wasn't quite the same, with people being under the age of 74 making up 50% of our study, and they only make up 38% of the service. But we kind of expected that, and this graph just demonstrates that we do have a younger population. We struggle to get anyone over the age of 80. And the reason for this, we've hypothesised that it's to do with, because of the nature of the mental health service for older persons, the illnesses are degenerative. So it makes sense, the older they are, the less likely they are to be able to participate in our study. Cool, so our key results really is that people were interested. Both clients and carers, over 50% of the people that we spoke to were interested in being involved. And the areas they were most interested in was just sharing their experience. So whether it be with a staff member, just giving their feedback, but also a lot of them were interested in sharing with other clients. So for example, if someone was a bit nervous about having ECT or something, there was a lot of people that were interested in talking, someone who's gone through it before, talking to that person, trying to help put them at ease and things like that, which was very positive. Cool. So for the barriers, for the carers, there wasn't really much of a barrier. They really felt like if they wanted to be, they could be. And the 33% a good portion of it was just laziness. They just said they couldn't be bothered being involved. And for the patients, transport, and also knowledge, feeling like they had enough experience or to contribute something worthwhile or meaningful. Those are the biggest barriers for the patients. So in terms of contacting them, the carers, once again, they were pretty much happy to be contacted by everything. For the clients themselves, they preferred questionnaires, or they definitely preferred interviews. I think they definitely preferred in-person interviews as well, because there's a lot of they like to talk for a start, but a lot of other things that you couldn't quite get without being there and experiencing them in person. And they didn't like emails or social media, which wasn't much of a surprise. Cool. So from here, hopefully the idea is to write to the clients, let them know what we've found, and send out an invitation, inviting them to be involved if they like, and then hopefully from there making some form of register of the people interested in certain areas, especially with the willing to talk to others, patients and things. So if there is someone who wants help, they can look on that list and say these people were happy to help, and put them together. Sweet. So I just want to say a big thanks to everyone involved in both my studies. It's been an awesome experience for me. I think I've learned a lot, especially mental health looks a lot different in real life than it does in a textbook. So that's been a huge experience for me. And also I just want to thank Stucco House where I was based. They were awesome, and a lot of them are here as well. So cheers. Thank you for listening.
Hey, thanks, Marina. Holly. Our second Holly. Yeah, Holly Egan. Now, Holly, I see, was also a Ducks at Aquinas in 2011.
Yes.
Yeah, so your sponsor was one of the few that required the clinical school to be the actual sponsor. All the others, I'd have to say, thanks to the sponsors, the provider arm, planning and funding from within, BoPMRT, Venturo and Auckland Uni. Thanks to the sponsors as well as the supervisors. And your supervisors were Rob Cunliffe and Adrian Claydon, so thanks to them as well. And gastroenterology, referral and grading audit. Thanks.
So hello everyone, my name is Holly Egan, as Peter said, and so for the past 10 weeks I've been with the gastroenterology department, and my study was a referral and grading audit. So just a bit of background. At the moment, due to resource constraints, the waiting times for colonoscopies are currently surpassing national guidelines. So that pretty much means for a case, if they're graded grade 1 versus grade 2A, it means that there's about a difference of 3 months in waiting time. So that means that accurate referrals are more important than ever to ensure that a patient is treated within an appropriate time frame. And so basically the study arose because of a need to look into those processes and just see how accurate things are, and also just to identify any areas of future improvement. So the aim of the study was to review clinical referrals for elective lower endoscopy to assess the referral indications and evaluate priority grading as compared to national guidelines. So how do we do it? So the study was a retrospective review of online clinical referrals, and these were performed at Tauranga Hospital during July and August 2014. A total of 137 patients met the inclusion criteria, which basically just specified that a case must be a first presentation for a lower endoscopy. For each case, the referral history was compared with the history taken by the proceduralist when they met with the patient. The assigned priority grade of the patient was also compared to national guidelines, and this was done by generating an objective grade using the same guidelines that the proceduralist had also used. And lastly, the clinical findings of the endoscopy were also reported. So in terms of results, for comparing the referral histories with the proceduralist histories, there was a 90.5% consistency rate, and as you can see, all 9.5% of inconsistent histories were GP referrals, and interestingly, 70% of those were actually due to the GP ticking a high-risk box on the referral form that the patient didn't actually qualify for. In terms of evaluating grading, there was an 82% consistency rate between the grades. The 18% of inconsistent grades was compiled of 4% downgrades, 6% upgrades, and 8% justified upgrades. And justified upgrades were basically determined from information in the referral letter and just by discussing with the proceduralist on a case-by-case basis. Common reasons were other malignancies, anemia requiring blood transfusion, and having a strong family history as well as being symptomatic. In terms of clinical findings, as you can see, 31% of all colonoscopies for the study participants was normal. The most common abnormal finding was a polyp measuring less than 1 centimetre, and the colorectal cancer detection rate for the study participants was 10.2%. On further evaluation of the colorectal cancer detection rate, as you can see, it was 8.9 across consistent grades, 0% in upgrades, 27.2 in justified upgrades. And unfortunately, one of the 14 cases found with cancer was downgraded, so it was resulting in the 65% rate there. And on further talking with the proceduralist about this case, although the referral letter was quite vague, it definitely was graded lower than it should have been, which is unfortunate. And lastly, this is just really representing that for all the patients found with cancer, 57% of them were graded grade 1 according to the proceduralist, whereas had they have stuck to national guidelines, only 36% of them would have been graded grade 1. So finally, in conclusion, just in an environment we have to prioritise, it's essential that this is accurate to ensure that a patient does receive treatment in an appropriate time frame. And really the study is just showing a few areas of potential improvement to the access of colonoscopies.
James, you can spot the family resemblance instantly. He's been working with Barry Neal, thanks to Barry, who was a supervisor looking at trans-radial access for coronary intervention. And James also is a prodigious sports person, having represented New Zealand in beach and indoor volleyball.
Thanks, Ted. So I was with Barry Neal, a cardiologist, and Jason Money, a cardiology nurse, over the summer looking at this project. So transradial reaccess complications for coronary angiography with percutaneous coronary intervention, also known as PCI. So a bit of background. The transradial approach for PCI is favourable compared to the femoral approach, is what they've done in past decades, because it has reduced vascular complication and bleeding. And so its use over the last 2 decades has steadily increased. And at Tauranga Hospital, you can't always have your PCI and your angiography at the same time. Sometimes it needs to be done in 2 steps for various reasons. And so that's why reaccess complications we thought were important to look at. So what is transradial access? I've got a wee video to show you.
A needle is inserted through the wrist into the radial artery. A guard wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope.
Sweet, so yeah, pretty self-explanatory. So for the method, we had patients undergoing single and repeated transradial catheterization between April 2012 and December 2014. So single access was when you had angiography and PCI as a single procedure, and re-access was when you had angiography and PCI as 2 separate procedures, or as all repeated PCIs. And complications were defined as vascular problems, bleeding problems, or failure to access the radial artery. And we used both left and right radial access. So the BARC score, that was the way we classified bleeding complications. It's a more sensitive scoring system than other surgical scoring systems, such as the TIMI score, because and so it's good for this procedure where complications aren't usually that severe. And so you've got BARC 0, which is no bleeding, or modified by a local team to have expected minor bleeding. So usually when you have radial access, you're going to have a small bruise, and if it can be covered by your hand, they kind of deem that as expected minor bruising. And then you have a BARC 1, which is when the bruising extends further up the forearm significantly, and then a BARC 2 where sometimes you reach the bicep and it can increase your length of stay in hospital. And then the other BARC 3, 4 and 5 didn't actually turn up in the study. So for our baseline characteristics, the demographics of the single access and re-access groups were approximately the same in terms of age, gender and ethnicity. Also diabetes was equal. There was a couple, so lysis and screening time, a couple others had significant associations, but we'd put that down to a high proportion of acute cases being in the single access group, and so we were quite happy with those associations. Results, so there was 246 single access patients and 224 re-access patients. In the single access group, there was 12 complications, and the re-access there was 13 complications. So both had a 95% success rate, which worked out quite well, and there was no bleeding more than a Mark II, like I said before. So here's in a graphical form, you've got, well, dead even in terms of complications, a 5% complication rate, and same with the BARC scores, you've got 1 or 2 or a 0, and there's, once again, it's pretty even in terms of the number of BARC scores that were recorded. So, in conclusion, repeat transradial access with PCI is feasible and safe, and with a low rate of both complication and failure. And the modified BARC scoring system that the team did here allows for remote follow-up with patients, so over the phone, and enables non-clinically significant bleeding to be recorded and compared. There's my references. Thank you.
Kate Seddon. There you go. You all ready to go?
Yep.
Yeah, Kate's an Aucklander in Otago,
Yep.
prefect at Parnell College. And Kate's been working with Kendall Crossan as your supervisor. Kendall, are you here? Excellent work. And Peds and CAMS. And she's going to present a review of services for paediatric patients with eating disorders.
Okay, so okay, as Peter said, and he explained the title as well, so I'll just skip this slide. So eating disorders, they're a group of serious diseases which have a psychological basis with profound physiological consequences. We have a high prevalence in New Zealand with an associated high mortality rate, which comes both from the physiological complications and the risk of suicide. It affects children and adolescents at a time of important physical, mental and social development, and therefore is an important health issue. I reviewed outpatient and inpatient services at Tauranga Hospital. The purpose of the audit was to review the incidence of patients coming in, what their characteristics were, what treatment they received and what their outcomes were. For outpatient services, I reviewed from October 2010 to October 2014, where we had 63 outpatients under paediatrics or CAMS diagnosed with an eating disorder. Were the numbers increasing? They appeared to be stable. However, this was limited by the short time frame of only 4 years and the relatively small numbers. What were the characteristics of the patients? Patient characteristics were comparable to other eating disorder populations found in research, as they were predominantly female, mid-adolescents from middle-class families and diagnosed with anorexia nervosa. However, while they characteristically fit the stereotype for patients with eating disorders, there were a broad range of demographics with different ages, ethnicity, and socioeconomic statuses. And this is consistent with other research which shows the diversification of demographics of patients with eating disorders and stresses the importance of being able to detect eating disorder cases if they don't fit that stereotype. What treatment do patients receive?
Attention, we're about to test the fire alarm. Test only, repeat, a test only.
Do I just keep going?
Yeah, keep going.
So the first line of treatment is family-based therapy, or FBT. Let's wait for a second. Okay, so 50% of patients were offered this, and 80% of those patients
now
accepted.
Complete.
With 60% receiving just FBT. Reasons for not offering FBT included the family situation, if that was difficult, if there was domestic violence, abuse, or they just didn't like their parents, eating disorder if it wasn't the primary diagnosis, or FBT was not available at CAMS, which was in the early years of the study. Reasons for not doing FBT was a lack of patient or family engagement. Others received individual therapy, family therapy, or CBT. What were the treatment outcomes? Full recovery includes the cessation of physical, behavioural and psychological aspects of the disease. Clearly, here we have a significant improvement in physical outcome measures, with a 10% average increase in BMI, 12% average increase in weight, and the return of menstruation 2/3 of cases where they'd lost it with their eating disorder. However, only half of the patients achieved ending disordered eating behaviour and disordered cognitions. Therefore, they only achieved partial recovery. This is comparable to other studies who used FBT and other therapies. However, there's clearly room for improvement. For the inpatient service, we looked at the same time frame where 17 patients were admitted with a total of 25 admissions. Were the numbers increasing? The numbers did appear to be increasing, however this is limited due to the small numbers and again the short time frame. What were the characteristics of patients? They were the same as the outpatients. Why were the patients admitted? So, they could be admitted for medical reasons if they were medically unstable or had rapid or life-threatening weight loss. This accounted for 8 of the admissions. They could be admitted for psychosocial reasons, which included exhausted family or deterioration in outpatient care. This accounted for 7 admissions. And a combination was found in 10 admissions. It brings into question whether the patients with just psychosocial reasons for admission needed to be admitted into hospital, and whether a day centre may be more appropriate to help patients by providing a less restrictive environment and the cons of being admitted to hospital, as well as significantly reducing costs, which we're looking into now. What were the outcomes? So the average length of stay was 38 days, which is comparable to other studies. There were significant improvements in physical outcomes with an 11% increase in BMI and a 10% increase in weight. However, all of the discharge criteria were only met in 56% of cases, and this included things such as whether they had safe eating, whether they were confident to start outpatient care, whether the family were confident to offer meal support, and things that would help them transition out of hospital into outpatient care, and is therefore important. Overall, we found that patients were accessing services, and these were in line with best practice. The aim is to look at the sub-analyses to further improve services. And I'd like to thank Kendall Carson and everyone who helped me at CAMS as well. Thanks.
Sam McDiamond. Sam's helped us out a few years ago with the business case for the simulation equipment. So anyone who's doing simulation around the hospital and enjoying those devices, Sam had quite a bit to do with it. So we offered him a summer studentship, his relationship to Andy notwithstanding. And he worked with Brian Dwyer in emergency and looked at sepsis for patients presenting to the ED.
Right. Good afternoon, everyone. My name is Sam McDermott and I am a second year medical student from the University of Auckland. For the last 5 weeks I've been working alongside Dr. Brian Dwyer, and together we've been looking at the effectiveness and timeliness of identifying and treating patients presenting to ED with possible sepsis. Due to starting my studentship relatively late this summer, I still have another 5 weeks left here at the hospital, and as such we have only just completed the data collection phase of our project and are still yet to conduct any analysis. However, I thought I would take this opportunity to discuss why we are conducting the research, outline the project aim, give you a snapshot of where we're at, and consider the implications of our possible findings. So, why investigate the identification and treatment of sepsis among patients presenting to ED at Tauranga Hospital? Well, firstly, there is very little current information on how fast we are at identifying patients who present to ED with a systemic inflammatory response as a result of infection. In addition, there is very little information on the incidence of sepsis within New Zealand. It is also estimated that countries with an ageing population, such as New Zealand, will see an increase in the number of patients who are presenting to ED with sepsis, severe sepsis, and septic shock. This is especially relevant to Tauranga Hospital due to the fact that we currently have no specific protocol for identifying and treating patients with potential sepsis. Now, there is also controversial literature around the treatment of patients presenting to ED with severe sepsis or septic shock, but unfortunately we don't have the time to discuss that today. But what we do know for sure is the fact that, or what the literature does agree on, is the fact that early identification and treatment of sepsis greatly improves patient outcomes, reduces the length of stay in hospital, and decreases the burden on public healthcare resources. So, what is it that we're actually planning to do? Basically, we want to investigate the relationship between patients who have a raised early warning score on ED admission, inflammatory markers, and/or a diagnosis of sepsis during the patient's time in hospital. We will then proceed to look at the time between the initial measurement of vital signs and the subsequent request for blood tests, blood cultures, and antibiotic administration. In terms of what we're looking to achieve, we're hoping to identify how efficient and how effective we are at recognising and responding to patients who present to ED with a potential underlying infection. So where are we at right now? We have collected data for all patients that came through ED and were admitted to general medicine or general surgery from the 15th of December to the 15th of January. We have also recorded the first vital signs taken in ED and used this to calculate an early warning score for each patient that was admitted during December. We have acquired and categorised lab results for most patients that have blood tests and cultures taken in the first 24 hours after ED presentation. We have created a large database that consists of all data we have collected so far. However, we are still waiting on a small amount of outstanding data before we can begin any analysis. So, what is the clinical relevance of this project? Well, we hope to provide statistics on the current times that it actually takes to identify patients who are potentially septic, and then the subsequent times that it takes to request blood tests and cultures, administer antibiotics, and provide additional treatment. It will also allow us to compare our performance with international response guidelines, which have been developed by the Survive Sepsis organisation. We also hope that it will highlight areas where possible improvements could be made. For example, the need for further staff training and education, or the implementation of a sepsis screening tool that could be used in ED and other wards throughout the hospital. And that's all I've got time for today.
Glenn Gabrielson worked with Graham Porter on, Graham's here, right behind you. Did you know that?
I did.
Yeah. On the congenital heart disease database, and it's Glenn did a BSc in Otago, and I'm pleased to say you're joining the staff.
Thank you.
Fantastic. Come and tell us.
So hello everyone, my name's Glenn Gabrielson, and I was given a summer project by Dr. Graham Porter to create a database using Microsoft Access. The database was set up for patients that have been seen throughout clinics at Tauranga Hospital, and generally these patients included in the database were grown-up children with congenital heart disease that was diagnosed in the remote past. So just an introduction to the problem. Patients with adult congenital heart disease had their notes available, but they were located in a range of different places. Having this information stored in an unorganised fashion made it difficult to keep track of patients, and so the project was sort of structured around this unorganised problem to make it easier for Dr. Porter so that he could bring up all information about a particular patient before seeing them in a clinic, easily update patient files after seeing them in a clinic, and then also to see how clinics are running to be able to plan resources around these services. So I'll just take you through what a database is like. So usually when you open up your database, it will bring up a main menu type page where you can search for a particular patient through something specific to them, like an NHI number, and then you can also add new patients in. So if we clicked on the add new patient, it would bring up a range of forms that you would have already had to create, and you'd put in things like ID number, last name, first name, etc. And then you'd click on a medication kind of tab, and you would put in their medication that was specific to them. So if we were to go back to our main menu now that we've added in all of our patients, we can now search them through their NHI number, and I've put in 1, 2, 3, 4. And then if we click View Patient, it will come up everything relevant to that patient through the form. So we've got patient details, first name, last name, and if we click on medication, it will say that this patient's currently taking paracetamol. So that's the general idea of how a database works and when you would use it, and I'll just take you through the advantages. So the main advantage of using Access is that you're able to create queries, and this function is the ability to ask the database particular questions. The statistical information that you get out of the database can be particularly important to give an indication about the types of resources your clinic is using so that you can plan and funds accordingly. So here I've created a simple query. We've got looking at all the patients and the medication they can take. And down the bottom I've got an exclusion criteria here, so we're only going to look at patients that are taking paracetamol. And when we click run for that query, we see that in our database, one patient is only taking paracetamol. And so that would come up with all your patients, and it would give a number, a tally at the bottom, and you could say you've got 20 patients out of 100 taking paracetamol. So some disadvantages about using Access. The main disadvantage is that it's a very steep learning curve, and so it requires a good amount of time to be able to understand the simple basics. But then once you understand that, it's quite easy to be able to do this really effectively. Another disadvantage is that all the data is saved onto one file, so obviously it's quite easy to delete data. And then as you start to fill up the maximum space on Access program, it's about 2 gig, it will actually start to slow down the speed that Access can perform, and therefore the speed at which you can do things also decreases. And so to finish, I'd just like to finish on the lessons I've learnt. So make sure that all your data fields, when you're starting to add in patient data, that they're really well defined, because it takes a lot of time to go back through patient notes and try and fill out this data. And when the database becomes a multi-layered system, here I've created all the tables that are related to the main table. You can see it becomes quite muddled and become quite a problem. If you don't label these tables exactly the same in the main table and the other tables, Access will pick up that there's a bug in the system. And to be able to go through and find out where this bug is, it's a real problem to be able to find. So make sure your data fields are well defined. Okay. And then finally, I'd just like to thank the Clinical School and Dr. Porter for giving me this opportunity to conduct research at Tauranga Hospital, and I've really been enjoyed doing this, so thank you.
Liam Walsh, who was supervised by John Malcolm, based in Whakatane primarily. Yeah. Liam's our second University of Auckland student. And head boy and ducks of John Paul College, I've got here, but more interesting is the fact that he was 6th in the Queen Street Mile Open Men's category in 2014. Prodigious runner.
Yes, thank you for that introduction. I don't know if that's the prime achievement of my life, but I'll claim it. I'm not sure how long I'm going to be talking for, because I do have 2 projects, and so hopefully I'll be within time. Okay, so my name is Liam Walsh. I'm from the University of Auckland. I've been working with John Malcolm, paediatrician based at Whakatane District Hospital, and also I've been helped along with my stats by James Scarf, so I thought I'd just mention him here. So I've been doing 2 projects. The first project is concerning the age, gender and ethnicity of acute rheumatic fever patients in the Bay Clinic. I'll talk about that first. And secondly, we're going to look at throat swabbing programs and their effectiveness within the Bay Clinic region. Okay. Right, so acknowledgements, I'll come to that at the end because I don't have very much time. Okay. Right, so this is the premise of this study. So basically, you can see here that we've got the age-specific 5 to 14 years incidence of acute rheumatic fever, so the incidence per 100,000. If you look at the New Zealand incidence per 100,000, that's 13.8. And if you look at some of these areas within the Bay Clinic, you can see that their incidence is far, far higher than the national average. So that would mean that we probably should be getting some intervention programs to help with that. And so this is just a visual sort of representation of those areas again. If you look at this red line, that represents the New Zealand Heart Foundation threshold for a school-based throat swabbing program. As you can see, the incidence is far, far higher than that red line, and so that was how the throat swabbing programs came to be. Okay, and then just lastly, this is a graph by Stephen Twitchen, basically just showing that there is a difference between the western and eastern part of the Bay Clinic. Even though the confidence intervals may be slight over that, you can still see there is a significant difference there in terms of the rates. Okay, so this is what I found. So in the overall age distribution of the acute rheumatic fever cases from 2014, which is what we looked at, we saw that most of the cases were based around school-age children. So that was 5 to 18 years old. And we had a lot of it centred around intermediate-age children. So that was 11 years old there. In terms of tail ends, on the left-hand side, you can see there's slightly more of a tail end than on the right-hand side. So a few more older cases there than possibly in the 1 to 3-year-old category. Okay, right, so if we just look more specifically at the distribution within school-age children, we can see that 90.5% of the cases that we identified were within school age. So we think that these throat swabbing based programs are mainly targeting all of the target population that we need to address. And then if you look particularly as well, particularly 5 to 15 age, because even with the 3% off, that's still 87% coverage there. All right, and so then in terms of gender, we saw that almost 70% of cases were male, with only about 30% female. So we're going to do further analysis on that. It's quite interesting to see that there's such a significant difference in terms of gender, but we also haven't been able to do that yet. Okay, and just a breakdown of the ethnicity now. So when we looked at the ethnicity, which was coded by the Ministry of Health, in terms of on the coding sheet, official coding sheet, and then we compared that to what was actually recorded by the patients or the patients' parents themselves, we saw there was actually a significant difference in terms of New Zealand Māori people. There was an increase of about 10% there, and then with New Zealand European, that actually those numbers actually halved. So that was quite interesting to see the differences there. And then overall, we saw that 95% of the cases were Māori or Pacific people, with only 5% New Zealand European. Okay, right. So when we looked at all of the ethnicities that were recorded by the patients themselves, we saw that there was more of a greater diversity than what would be just represented by a single prioritised ethnicity. But then again, the majority were still New Zealand Māori. Okay, right, so the method. We looked at the BoPDHB discharge codes for ARF diagnosis. We looked at EPSF notifications when it's notified to the Ministry of Health. We looked at the Central North Island databases that were collected for ARF patients. Then I went through and checked that all of these patients met the 2006 National Heart Foundation guidelines for diagnosis of rheumatic fever. I subjected them to the inclusion and exclusion criteria, which I'll go on to in a second, and then I looked at the code ethnicity versus what was actually recorded by the patients or parents. Okay, so inclusion criteria, they had to have ARF as a primary or secondary diagnosis. They had to be enrolled in a school in the study area and also attending that school. They were excluded if they're enrolled in a school but not attending it, if they were resident in the study area but not attending school in that area, and they were also excluded if we identified that they did have rheumatic heart disease but that there was uncertainty of year of origin of the acute rheumatic fever or where it might have been outside of the study period. Okay. So we allocated the cases to an intervention area or control area, which I'll show you in a second. Then we analysed that by year and age, and then we aggregated the intervention, and we also aggregated the control areas to look at trends and data, and then we got school populations, and we used that as our denominator for rates. And then once we calculated those rates, we also combined a pre-intervention period and then a post-intervention period. So this is just a quick map of the deprivation, and this is where the schools were in terms of intervention area schools and control area schools. And so this is our stats. We showed that in terms of the rates, 5 to 14 overall, we saw that there was, when the interventions were implemented in 2011, there was a significant decline within the intervention areas in terms of the rates, where even in 2013 they seemed to cross under for the first time the rates in non-intervention areas. And then that was similar for the Māori rate, 5 to 14 years. And so then just quickly with this, I've got 2 more slides. Just quickly, we aggregated the pre-intervention, post-intervention areas. In the pre-intervention area, we saw, we saw a drop from 128.7 down to 50.7. And when you look at those confidence intervals, there's not very much of an overlap at all in terms of that. So we think that this drop is actually heading towards statistical significance in terms of showing that our intervention programs are working. And then again, same thing, looking at the rounded numbers, a drop again. If you look at the rate ratio, it's indicating that there's a significant drop. The confidence interval there is below 1 for both lower and upper number, so showing that there would be a drop the whole time. And the p-value is below 0.05, so it does show significance there. So just thank you. That's all the people I have to acknowledge, quite a few. Thank you very much.
The slides are going to be on the clinical school website. And I forgot to mention Grace Hospital when I was talking about the sponsors before as well. So I thought I'd just add that. And the supervisors, thanks once again to all the supervisors, much appreciated. And we'll be hitting you up again next year for some worthwhile topics. And of course the sponsors. We've got to pay these guys. We didn't pay Sam last time, but we have to pay him this time. So thank you all for coming.